So I'm Caroline. We've got Felicity, who will be speaking a little bit later. We've also got Catherine Willis, who does our role but works down in Wessex. We've got David Church, who's our medical sort of clinical lead. Sarah Hewitt, who's our project manager. And we've got Lisa Dew, who is the programme manager. So where are we up to with the project? So you may remember sort of scrolling back a few years ago, every MDT was asked to complete an audit. And this was 30 patients, and it looked into sort of age, the histology of their cancer, what the MMR showed, and obviously methylation and BRAF as well for colorectal cancer. And it detailed whether they were referred to genetics. So after doing that audit, we arranged some feedback, and then we had some discussions around mainstreaming and then offered training to the teams. And this training was really sort of support to set up a clinic with the aim to bring patient discussion within house. So it was about giving informed consent, getting a blood test for that genetic screening, the R210 panel. And then obviously the main aim really was to downsize the time that they were waiting for a diagnosis of Lynch from around sort of 6 to 12 months to a matter of weeks, so that we could get them diagnosed early and get them on preventative treatment and surveillance. So it's really a massive congratulations to all of you really for your hard work. So you can see, particularly within endometrial cancer, the MMR testing rate has risen significantly since 2009. This is the most up-to-date data. The sort of latest data is being correlated, but it has gone up sort of even further. So, you are doing really good work, and we are very appreciative. Same for sort of colorectal, it has gone up significantly as well. So again, a massive well done for that. So looking at an overview, so we cover quite a large region. So we cover the West Midlands, we cover Thames Valley, and also we cover Wessex. Primarily sort of Felicity and myself, we sort of generally cover sort of West Midlands and Thames Valley, and Catherine will cover Wessex. So across sort of the central region and Thames Valley, we've got 24 endometrial MDTs and 26 colorectal MDTs. Felicity and I split these evenly between ourselves. However, we both sort of try to attend all meetings just to ensure that there is always support for all sites and that everyone, is covered in the event of sort of annual leave or sickness. And 90% of those sites have a named Lynch champion. That has gone down recently due to somebody leaving post, but we do have somebody who's very interested in taking up that post. So that hopefully will go back up to sort of 100% very soon. So general sort of view across the West Midlands region. So colorectal, we've got 12 colorectal MDTs within that central region, but 14 teams. So we've got, different hospitals that may feed in just to the one MDT. So 92% of you have completed your audit, so well done. 82% have received an audit feedback, just the one declined. 43% have undertaken mainstream training, and at the moment we've just got the one site who is mainstream, which is the QE. We've got one site that's recruiting a CNS to cover both colorectal and gynecology, and we've got a few sites that are going to be coming online sort of very, very shortly, just waiting for the fine tuning of sort of finances and paperwork to go through sort of Q&A. So again, across the West Midlands with the endometrial side, we've got 10 MDTs and 12 teams. 90%, so a huge number, have returned the audit, and 78% have had that feedback as well. One site has declined, and we've just not managed to reach one of the other sites. So 33% of those 12 teams have completed mainstream training, and at the moment we've just got one site that was sort of prior to us commencing in post that is mainstream at the moment. However, again, we are sort of imminently expecting other teams to come online live relatively soon. So within Thames Valley, We've got 7 colorectal MDTs across this region. It's a little bit more difficult because we've got 3 cancer alliances that cover that patch. So obviously getting funding, fine-tuning details can be a little bit difficult, depending on sort of how much support the cancer alliances offer, and sort of what their guidance is. So 86% have completed and returned that audit. 1 is still outstanding, but that is in the process of being done at the moment. All sites have had audit feedback or are just awaiting a date for that. 57% of the 7 have completed mainstream training, and 2 sites are deciding to set up a combined clinic. They're just awaiting sort of clinic codes this week, so that should be pretty imminent that they're going to come online as well. So the endometrial within Thames Valley, we've got 7 MDTs across that region. Again, same issue with, we've got the 3 cancer alliances. So obviously guidance and different things and funding can be a little bit more complicated with that. 71% have returned that audit, and 2 are in the process of being completed. All sites that have returned audits have had that feedback meeting. Just the 1 site at the moment has undertaken mainstream training, and we're just awaiting a bit of an update really on their clinic plan, as they may also choose to do the collaborative approach and cover 2 sites at the same time. So I'm going to pass you over to Catherine if she's here, just to give you a little bit of an update on Wessex.
Thank you, Kat. That's great. I loved your slides, and I've just got 1 slide to sort of give you an overview of what's going on in Wessex. So hopefully I'll be able to cover everything just looking at this one. So as Kat said, we did have a slightly different approach. My background is actually in clinical genetics. So I've been leading the Lynch project in Wessex, and our Cancer Alliance have been very supportive. And we actually took the approach of training. Well, we had 7 clinical nurse specialists to start with, and we're just getting on board the trust that didn't have one. They are now recruited, and we'll have somebody in colorectal very soon, and then gynae just after that. So those 7 CNSs were trained on the national training for mainstreaming, and we're now running some localised training for the rest of the teams that are going to be involved. So just quickly to run across there, we've got, I think, less trust than you have in both your regions, Kat and Flick, but we have 1 big gynecology MDT that encompasses a few of our trusts, and then the others all run their own MDTs. So we've been training somebody in each of those. There's a Lynch champion in all of them. We've completed audits for all of ours, and we're planning to redo those audits towards the end of this year to really see what the impact of the mainstreaming is at that point. All of our audits, we did some of them more than once, but they are all over 90% for the immunohistochemistry testing for mismatch repair. And so off the back of that, we felt that everybody was ready really to introduce mainstream germline testing. So you can see as you go across, we've got a Lynch CNS in most of our areas, but unfortunately, because the funding has had a hiatus, we've lost a couple of our CNSs currently. We're hoping that we'll be able to get them back on board once the funding's been signed off again. And as I said before, we had a gap in one of our trusts, which was actually Portsmouth. We have now got somebody for colorectal, and we will have very soon a gynecology clinical specialist coming on board. So in terms of mainstreaming, we have just launched our mainstreaming. We've now got 2 of our MDTs that have seen 2 patients each. So that's the Southampton colorectal MDT and the Dorset gynecology MDT. And I've noticed that Seema's on this call. So it's massive thanks to her, who's one of our CNSs. She has started the gynae in Dorset, and she will be rolling out colorectal in that area as well very soon. And the others, as you can see, are in either the planning stage or about to happen, except for Portsmouth, which obviously we're a bit far behind because we haven't had those clinical nurse specialists in place. So we want to sort of get them up to the level that we've had for the last year, training our other CNSs. That's probably all I wanted to say. I did notice Seema's hand just went up, so I'll just pass to her and if she wants to make a comment at this point. Hi, Seema.
Hi, Catherine. No, I was
Hello.
just putting the thumbs up that we managed to
Oh,
start
sorry, I
the
thought it
clinic.
was your
Yes,
hand.
that,
Couldn't
no,
see.
there's nothing else to
Yeah,
say. We are on the process of starting the colorectal, but we are going to have a meeting with the team and then we'll decide when we are able to start this. But we are hoping to start it soon. Thank you.
brilliant. Yeah, that's great. And we've got our Isle of Wight colorectal and gynae nurses they're seeing a gynecology patient between them. They have quite a small MDT, so they're cross-covering each other. And we've also had the advantage that we have rolled out mainstreaming for breast ovarian. So some of our gynae nurses are already trained in that and are very confident in the idea about mainstreaming. And as I said before, we have run 2 local sessions. So what we've planned to do is a remote online session in the first instance, which is 2 hours covering the genetics and the sort of background of everything. And then I will then go and do a second session, which I will do face to face with the team that's ready to mainstream. And that's more about the sort of paperwork and the actual practicalities. And then talk around setting up clinics and clinic codes, which we've been liaising with our CNSs to do that. So yeah, thanks very much, Kat. And any questions I'm happy to answer, obviously.
Can't see whether there's any hands up, so I have to apologise if I miss anything. But thanks so much, Catherine. It's really, really wonderful. So it's just to make you guys aware of obviously the Lynch Syndrome registry. So this was a pilot study to address sort of differences in access, quality, timeliness of regular checkups. And the aim really was for equitable, sort of efficient, nationally coordinated care for all of our Lynch patients. And the hope is that this will become a central resource for sort of research and obviously help to support sort of further studies. I've embedded a link there to that. So what it was a total of almost sort of 12,000 sort of retrospective and almost 600 prospective data submissions that were received. And this resulted in sort of the first kind of comprehensive English national sort of Lynch syndrome registry. So it was just over sort of 9,000 unique individuals. What it showed was that we're not actually asking people about ethnicity. So of the sort of over 9,000 people, 8,711 were not asked. That's 96%. And obviously, if we are looking at sort of, you know, focusing care on getting that equality, we need to know whether there are inequalities in the first place. So what we're sort of saying is that if you are kind of seeing patients in clinic, just make sure that you do ask that ethnicity so that you can pop it on the form for genetics. And the reason for that is there is sort of a huge sort of socioeconomic deprivation sort of quintile issue here, that the most deprived areas are actually more likely to have a deficient MMR. So you can see that with that there. And obviously thinking about kind of people that live in the most deprived area normally come from sort of ethnic minority kind of backgrounds as well. The benefit of obviously getting patients within that predictive testing and getting people kind of either on aspirin, having regular colonoscopies, is that they're actually more likely to have an early stage cancer when they're diagnosed than sort of a stage 4, which is the most advanced. So you can see from here the general population, you've got 24% that are, showing up kind of with a stage 4 cancer, whereby if you're going into predictive testing with the Lynch population, it's actually going down to 3.8%, and that's going to have significant benefits for the cost of treating cancer, but also patient outcomes. They're more likely to get a better quality of life back and actually recover. So that's a really important thing to obviously say. So one of the recent things that has come out is we've set up now our regional expert network meeting, which you may hear called REN. So what this will do is it will cover the West Midlands region, it will cover the Thames Valley region and Wessex, and it will have cross links to all areas and the national team. So we had our first regional expert network meeting a couple of weeks ago, and the plan is that that meeting will focus only on Lynch sort of initially, to just ascertain the workload required. We've advised that our next meeting will be in September, and the aim of this network will be about supporting mainstreaming, discussing sort of challenging cases, bringing best practice and the most up-to-date research and metrics, and obviously education as well. And obviously it will be there to discuss sort of any other business or queries that we may have. So what the Regional Expert Network will offer is remote specialist MDT meetings, or a virtual review of patients from other centres who will still receive their management locally, but for whom we can help you give support with management decisions, discussion around sort of specific treatments, for example, sort of extended resections. The current plan is to meet every 3 months. However, this may change based on referral numbers and just momentum of meetings. We are happy to review variants via email ad hoc. So if you have got any queries, you can email us. And currently we've got a web-based form for referral, which will need to be emailed to this address that we've set up. And this is the form here. So obviously what we need you to do is obviously put in as much clinical information as you can, as unfortunately patients won't be listed if we haven't got that sufficient clinical information to go from. Okay, any questions at all?
We've just got one from Kyren.
Okay.
Hi, Caroline. Hi. Can I just ask a quick question about variant review? What context are you talking about in that, in terms of variant review?
So if people have got any sort of issues or any queries around any of the variants, obviously what we'll do is we'll have that emailed, and we'll refer that over to the clinicians to obviously review and discuss. So it's really anything that anyone's unsure of. So it's not specific to certain variants, it's just anything that people are unsure of.
Okay, so I'm just wondering, I can't remember off the top of my head how much variant of uncertain significance type stuff gets reported, but I think the labs, I can't remember the policy on that. Are they reporting VUSs, and is that the issue that we're talking about here?
Yeah, so I mean, VUSs are generally going to be followed up in symptomatic service as well. So I think it'll be whether we discuss all the negatives, so whether we'll have the facility to discuss the negatives and make decision on obviously not referring them to clinical genetics and discharging, obviously reviewing the VUSs and also reviewing the positives, because those patients that obviously are going to be coming back as negative, if they are under 40 or they have got a significant sort of family history, so that they're meeting the Amsterdam criteria, obviously they will still need to be referred. So it's things like that, really.
Okay, that's great.
All right. So if Dr. George Brighton and Siobhan are here, I'm going to pass you over to them for the next part.
They haven't turned up yet. I am just chasing. So if we want to move on to the next section and maybe come back round.
Okay. So the next one is Felicity.
I'm muted. Hi, good morning. I'm Flick. You're probably well aware of who I am by now. I do apologise. Some of these slides are recycling those from those that were seen at the JFK event, but it's focusing more on training and what sort of services that we can offer. So I have the next slide, please, Kat. So again, this is just a bit of an overview of some of the things that myself and Caroline are able to offer. The majority of our role is based around trading. Obviously, we've been doing this a little while now, and what we focus on is initially sort of the core training. So what we've done is introduced ourselves obviously to MDTs, primarily gynae and colorectal as per the project, and basically introduced ourselves and introduced the project, but then also then focused on the actual diagnostic pathway for all newly diagnosed colorectal and endometrial cancers. We also felt at this point as well that we wanted to offer core training to other groups as well. So we do also offer training for administrative staff. We wanted to try and reduce this single point of failure. And we all felt that actually all members of the MDT played a part in a patient's Lynch pathway. So again, if you feel that you've got MDT coordinators or cancer navigators that you feel would be able to help assist with this pathway, do get in touch with us and we're happy to arrange training for them. The other focus of our job was really with the mainstreaming workshops, and we'll discuss this a bit later on as well. And with this, obviously, we weren't looking to train people as genetic counsellors. That's not what we're here to do. We've got a very good genetics unit that very heavily support this project, and will obviously support yourselves as well. What we wanted to do is help assist you to have these complex conversations with patients in order to kind of have that, bring it in mainstreaming into local hospitals. Just to clarify what mainstreaming means at this point, so mainstreaming was bringing that genetic appointment that we would normally send patients to genetics in-house. So that basically meant that CNSs or clinicians would be able to have that conversation with patients about having that blood test to look at whether or not they possibly have Lynch syndrome. Other things that we can help with was obviously just general advice, sort of helping to set up service, and obviously just troubleshooting and things like that as well. Next slide, please, Kat. Oh, I might need to take control. Skip that slide, it's fine. Skip that slide, it's fine. I was going to get you to do a couple of questions, but it's fine.
Won't let me skip it, unfortunately.
Hang on.
See whether I can.
Oh, don't worry, just skip to the next one.
It's loading. It is loading now. Okay.
No, don't worry. Don't worry, it's fine. So basically, quite often we get asked where do we start. So RM Partners, which are down south in London, they were part of the project team that started the development of this transformation project. There's a couple of there is a main website, and there are sections for colorectal, and there's a section for endometrial cancer as well. And on there are sort of just general advice. There is a bit of a change on the website, which I'll discuss in a moment, but quite often you'll get a lot of patient information leaflets off there as well. One of the main things that we would direct people to, and it has changed now, is the initial training videos, which again collate to which MDT you sit in. They have now moved, if we go to the next slide, they've now moved for e-learning for health, and basically, if you were to Google or any other platform which is readily available, if you typed in Lynch Project and then e-learning for health, that will direct you to that web page. If you just click that page for me, Kat. And then basically that's what will come up. And then if you go back to the slides, and then just click on the slide for me, Kat. That's it. So if you click in, and then it will bring you up to give you options. So like I said, depending on what your MDT are hoping to do, you may have you just want a general knowledge, you haven't got the staffing or infrastructure to offer mainstreaming at this point, but you just want the basics, you go to option 1. If you are looking to offer a mainstreaming service, then option 2 kind of helps give you that sort of, again, that foundation. And there also are sort of e-learnings for pathology as well. So again, if you click to the next slide, please, Kat. So when you log in, you'll be presented with these slides, and basically off that, you will then have a series of videos. Now, they are quite bite-sized. I think the longest is about 12 to 15 minutes long, but they are designed to sort of work around sort of your clinical commitments, really. And at the end of them, you do get assessments, and you do get a certificate, which is always good for your CBD. Next slide, please. So one of the other things that's recently come out, actually, it's only been out the last couple of weeks, is via Macmillan. They've developed a toolkit along with many members of the project team. It has initially started with a colorectal one, and I'm hoping an endometrial one will come back over soon, and we will let you know once that's available as soon as possible. But this toolkit basically, again, is a hub for all the learning that you possibly could want, and also sort of links to other sort of patient resources, or obviously trading as well. So again, a really good resource. Next slide. The other thing that we've got is obviously genomics education program, and basically one of the things that they've developed is GE Notes. This is quite useful to have on your desktop. Basically, it sort of helps, just if you've got a patient, you can just search in there with Lynch, and it will just pop up with some information that you can have within clinic. And then if you want a bit of a refresher, they also have like a bit of a knowledge hub as well. So again, you can just review that. If you just click on the slide for me, Kat, a couple of times. And again. That's it. So that's basically what you would get up. So you would, like I said, you would initially have information if you were meeting a patient face to face at that point. But again, if you just want to expand your knowledge, again, there's just bits for that as well. Next slide, please. So mainstreaming training. So here at CAS, we did things slightly differently. Catherine, again, just sort of very similar, but has her own sort of project down in Wessex, but up in Thames Valley and the West Midlands, myself and Kat run mainstreaming training. So one of the biggest things that we did was actually we kind of rewrote the book slightly with mainstreaming, because initially it was 6 12-hour sessions, which, you know, put a lot of people off because, you know, let's be honest, we're all very, very busy. So what we've basically done is we've incorporated all that was within the national training and condensed it down to 2 hours. So that makes it a lot more accessible. What we tend to do as well is we work, rather than setting dates for people to attend, we tend to say, well, actually, we'll meet you around your clinical commitments. That training, again, isn't exhaustive. So again, if you know, we do the initial training. If you need to do additional support, we can run additional training off the back of that. And again, we can offer support in setting up your mainstreaming service, and yeah, and flagging you to patient resources and things like that, really. So down the bottom there is just patient resources, nothing too fancy to kind of squint your eyes at. And if Kat very kindly clicks my slide again, what we do is, prior to the mainstreaming training, we do give you some additional reading, just some preliminary reading, just to help bolster that education. One of the things, and we're very grateful for Siobhan to be joining us on this call, but she has very recently had an article published, which again just helps to offer that foundation for the mainstreaming training going forward. So if click the next slide, please, Kat. If you can, sorry, if you can bypass that one. That perfect. So I mentioned genomics education program. Again, they've got some really useful resources on here. There is Genomics 101, which is again a set of modules. I think there's about 18 of them, but again, you can just pick and mix what you want. They are focused more generically on genomics. However, we're very lucky that there's been a CPI that's been developed, and that's a set of competencies. So again, if you feel that you want something a little bit more meaty, or you want to explore things a little bit better, or you want a set of competencies that you prefer to work towards, again, that's something that has recently been developed and is now online. So we will share these slides, so you'll get the link. But if Kat again magically clicks my slide, this is basically what will pop up when you click that link, and it will basically go through all the competencies from there. Again, if you are interested in sort of developing your genomics knowledge, if Kat magically clicks my slide again, again, there are further genomic training that you can do. There is something called the Fundamentals of Cancer, which is hosted by the Royal College of Radiologists, and Terry McPhee, who works down in London. She's very, she basically goes through sort of the genomic side of cancer. It is quite intense, but it is also aimed at cancer nurses. And, you know, if you want to develop your knowledge, really welcome that, really support in sort of doing that training. And then if you really want to go for it, there is also the Masters in Genomics. There is funding via the Genomics Education Programme, and information on that is via that website as well. Next slide, please. So obviously we've thrown all these resources at you. We've done your training and you're all set up. Obviously we don't want to sort of leave you in the lurch. So again, you know, like I said, we're not training you to be genetic counsellors, and genetics are still very much part of this journey and this project. So for us, myself and Kat and David and Sarah, obviously we'll offer general advice and support, particularly around, at the moment, around sustainability. Obviously we can offer you links to genetics. We've recently set up the Regional Expert Network, and then obviously can flag to other specialist MDTs. And then just general advice, really, and obviously setting up sort of local networks of nurses or clinicians, obviously to share sort of mainstreaming experience. Genetics will continue to manage all Lynch syndrome patients and their families. So again, if you've got specific Lynch questions, we may, you know, we're not experts in any stretch of the imagination, but, you know, we might be able to help with some of the simpler questions. However, you know, genetics will very much be there to help support and sort of help fine tune that those questions. They also help provide training. In the West Midlands, we've been very lucky, and Anna Considine has helped us formulate a lot, our training. So we've been able to kind of make it more bespoke. And again, being able to help provide sort of shadowing for clinics and things like that as well, and very much be there for support. Again, offering if you've got any queries and things like that as well. Next slide, please. So resources wise, obviously it is quite boggling as to what you can provide. We're going to learn shortly about an app that's been developed. Obviously you may have patients that want to know and have a look at various resources. One of the key places, if you have got a patient that's been newly diagnosed with Lynch, is Lynch Syndrome UK, which is the charity. Honestly, they are phenomenal. They have a really active Facebook page, really supportive of each other. Lots of questions on that Facebook page about how best to take your bowel prep. So, you know, just flag them to that if they really want that support. We have also got obviously other charities. So you've got Eva Peel, Bowel Cancer UK, and Cancer Research and Macmillan. Obviously, they are starting to develop toolkits, so, you know, patient information leaflets. In terms of if you want to write your own leaflet, go for it. But again, being mindful of the language that we use, the national reading age is around 9 years old. So again, we want to be able to provide resources for everybody. And again, that's something that myself and Kat will be looking at as we go on. Like I said, you've got RM partners who have also got some information leaflets on there as well. In terms of your own development and just queries, we've got the Association of Genetic Nurse Counsellors. Nurses now can be added as an affiliate member. We've also got the Cancer Genetics Group, who also provide up-to-date guidance for the management of Lynch patients. There's also the Genetic Alliance, which patients find quite helpful. They're particularly good to flag up if they're having problems with offering insurance and things like that. And again, most importantly, your local genetic lab website. Get to know your local GCs, and you know, they're really invaluable in the support that they can offer. And again, there are things a little bit further afield called, which is the European Hereditary Tumour Group, that we have just started a nurse committee, and we now have a committee member on the sort of board, the overall chairs of that committee. Next slide, please. So I hope that kind of clears things. I know it's a bit of a whistle-stop tour. If anybody's got any questions, you're more than welcome to ask me now. Yeah, go for it.
We've just had one question in the chat from Claire.
Yep.
So they've said, signing off the competencies, would it be yourselves, as they're not sure anyone in the trust is competent?
That's fine. Yes, so myself and Kat are happy to work through those competencies with you. We are here for hopefully up until next year anyway. So very much use and abuse myself and Kat. We're very much here to help support you in any way we can. So yeah, certainly working through those competencies we'll be happy to support. Anybody else? Clear as mud. Excellent. So we're going to have a quick 10-minute comfort break, if that's okay, and then
sorry, no we're not, because we've got the app to talk about, and then it's
okay, sorry, beg your pardon. No, so very pleased to welcome George and Siobhan, who are going to now talk about the My Sunrise app.
Thanks, Felicity. Thanks, Caroline. Thanks for inviting me. So I'm just going to share a few slides and give you a bit of an introduction to the work we're doing, and then I'll give a quick demo of the app. So take about 10 minutes, 10-15 minutes. Is that okay? Wasn't quite sure how long I had. Okay, great. So my name's George Brighton. I'm a GP in the Southwest with an interest in cancer, and I've been part of the team who've developed the cancer companion app called My Sunrise, which is live across Devon and Cornwall, and then more recently has been commissioned in the West Midlands through the Cancer Alliance. I'm just going to quickly share my slides. 1 second. There we go. Okay, hopefully. Can you see this? Sorry, I've got the new version of Teams, and I haven't quite worked out.
Yes, we can. Yeah,
okay,
it's all
great.
working.
Okay, brilliant. So yeah, so My Sunrise was set up in 2018, 2019, and the vision really was to support patients on treatment. It currently provides treatment support for patients going through cancer, treatment for breast cancer, colorectal, prostate, head and neck, and a few others. And then we met. Myself and the team ended up meeting Neil Ryan a few years ago, who many of you will probably know, and he had a vision for us to developing a pathway for Lynch syndrome patients, and really the vision at that time was to help them to find information about Lynch syndrome, schedule reminders, help them to administer health checks, recruit for research, ensure that they were getting updates about Lynch syndrome and about the management. And so that's really where it started. We applied to some funding from the Southwest GMSA, and they gave us a small pot of funding for us to develop the pathway for Lynch syndrome, and that's where we've got to. I won't go through all of this because I'm sure most of you will know a lot more about Lynch syndrome than I do. But when we first put together the proposal, we had intended to design the pathway around Lynch syndrome coordinators in the Southwest. So the idea is that the Lynch syndrome patients would be given a link to the app. They can download it for free, and then they could use it essentially as a reminder for them, and also for them to keep up to date with what's happening on the latest guidance, the latest management. So really the aims of it are to help empower patients, to help them understand who they can contact, to support them with their schedule of care. And then there was a few other things that we had some ideas for, so scheduled reminders and something called a Lynch syndrome passport, which Neil had designed, which I can show you in a moment. So let me just see if this is gonna work. I do apologise, I haven't quite worked out how to use this new Teams. So I was hoping just to give you a quick demo, but I can't quite work out how to make that work. That's annoying. Sorry about this. Okay.
Are you just struggling to get the video to work?
Yeah.
There's a weird bit that you have to do. Sarah, can you remember if you go into the more section, video effects and settings?
Yeah.
I think there's a bit where you have to oh, it's not that bit. It has all moved around. You have to do it so you start running the video. You have to take something off from your settings, and I can't remember which bit it is. Let me see if I can find it. I'll tell you what, I'll go off this, I'll have a play and I'll come back. You carry on talking.
That's great. Okay, I am sorry about this. It's the old Teams. I seem to know my way around, but I've just been forced to download the new one and use the new one today. So I'll keep talking. So hopefully we'll be able to give you a quick demo. But in terms of the project at the moment, we have launched the live version of the Lynch syndrome pathway for all patients across the Southwest GMSA. So it's being promoted and used by Lynch syndrome nurses and clinicians involved in Lynch syndrome. The idea is that it's given to them in their clinics. It's got a whole range of useful information about testing, about living with Lynch syndrome, and Neil Ryan's also done some videos that are included, which are really good and just kind of set the scene about what to expect, what treatment might be, what's important for patients to understand and for their families to understand as well. And then what we're doing at the moment is we have a working group set up in the Southwest with GPs, representatives from secondary care, and Siobhan, who is the Lynch syndrome lead in the Southwest. And essentially we are going through a process of evaluating this pathway with feedback from staff and patients, and we have a focus group happening in September where we're going to be getting some feedback from patients to see what they think about this and what they like, what they don't like. And then we're also pulling together some ideas about how we could improve this and how we could embed it into pathways and local clinics in a more effective way. And then the idea is that we are going to develop our phase 2 in the autumn of this year, which will include some of the things that I've mentioned. So the option for patients to develop a passport or a health checklist through the app that they can then share with their clinical team. And then there's a few other features as well that we've developed, like the Lynch Syndrome passport, which I'd be really pleased to share with you and show you. So that's where we're up to, and we're currently working with the West Midlands Cancer Alliance to develop My Sunrise into the Black Country. So we're working with Wolverhampton and Walsall and Dudley and Sandwell at the moment, and we're looking to try and expand and to join forces with other GMSAs to help us to develop this product and this pathway within other areas. So we're really keen to understand if there would be interest to work together with the Southwest to develop this for Lynch patients in your region, and to understand how that would work and how that would integrate with local systems. So at this point, I would love to give you a demo, but I'm not quite sure how that's going to work. There's a little I don't think I can. I'm really sorry. I don't think I can make it work, but I can put a link in the chat so that if you want to, you can have a look at it now. If people want to have a quick look, it's I'll just put a link in the chat. I'm not sure if anyone else is able to play that, but that would give a kind of a demonstration of the video. See if I can.
I can share my screen if you want me to. I could try
If you're able to, that'd be brilliant.
Yeah, that's fine.
Thank you.
Great idea.
Just checking there's no voiceover or anything on
No,
there.
it's just a simple a simple
that's
demo.
fine.
Yeah.
Okay, let me share them. Can everybody see that?
Yeah, so
that's come up now.
I can talk you through it. So when you download the app, as you can see there, you can choose Southwest or West Midlands, and then you choose where you're having your treatment, so where your local cancer centre is. So in this case, you can choose wherever I decided to choose. Yeah, Plymouth. And then when you go through into Plymouth, you can see there's lots of pathways available because we have My Sunrise in Derriford, but there is Lynch syndrome, and you tap on that, and then it pulls the My Sunrise Lynch syndrome companion to the patient's phone, and then there's a whole load of different sections of information. So this is this section called About Lynch syndrome, which is just links. So Neil and Siobhan wrote that section. Then there's a section on testing, which is again really simple information that you would, similar to what you would give in a patient information leaflet, and then some further information. And then that's living with Lynch syndrome is a video that Neil's done, which is really good actually. I would definitely recommend having a look at those videos or sharing those videos. And then there's a button for support, which is something we're working on at the moment, which is a way of basically patients getting in touch with either their clinician or their clinical champions. So in the Southwest, we have clinical champions in the trusts who are supporting this project. And then there's also clinical genetics on there, but we're not encouraging patients to ring through to the genetic centres. But So you can see that's kind of the phase one, the really basic version. And then what we're hoping to do is then actually, if you want to let that just run for a minute, just that next one, that will just give you a really quick idea of one of the videos that we did with. So this is living with Lynch syndrome. That has got some tech, some voice to it if you're able to turn it on. I don't know. So that's a video that Neil's done, which is really good actually. And we spent a bit of time developing that with him. So I'm happy to stop there, Caroline, and take any questions. Sorry, it's not gone as smoothly as as I'd hoped, but really happy to hear any questions, or if it would be helpful to share anything else at this stage.
Fabulous. David, do you have a question?
Thanks ever so much, George and Siobhan. That is really amazing. So yeah, massive kudos to you and of course Neil, who I know well, for working this up. It looks absolutely brilliant.
Thanks, David.
I just had three quick questions actually. First is data protection. How have you gone about that? The second is indemnity. Is that something that needs to be considered with these apps? And then the third is it a standalone, or are you going to try and get this adopted? Is it possible to get it adopted by the NHS app, which some patients or individuals will have already?
Yeah, really good questions. Thanks, David. So firstly, in terms of data protection, at the moment, patients don't have to log on to the app, so they don't have to put any identifiables in. It's we from the start, that's been a real issue in working with NHS information governance teams. So at this stage, it's a really simple resource that patients or their families can download and use on behalf of, or just have in their pocket. They don't need to put in their NHS numbers or anything at the moment. Down the line, if we develop more of an integrated service, that might be something that we look at, but we would approach that with when the time comes. So yeah, we have got we're fully compliant with DTAC, and we have gone through information governance with all of the council alliances, the ICSs and the trusts. So that's all been, we've ticked that off. In terms of indemnity, so obviously as an organisation we have insurance to protect against issues that might arise from use of this app, but mainly we have to include something called an end user license agreement, which is basically like a consent form that patients would sign up to when they use the app, and we try to make it as simple as possible. So this app is for information only, to support you with your diagnosis. It doesn't give specific treatment information for individuals or diagnosis information for individuals. So it's not a medical device. So from that point of view, it's indemnified in the right way. And the last question. So I think the NHS app is becoming more and more important, and we have been asked that a few times. How can we? So we're looking at how we can sit this alongside and work with the NHS app, because we know that that's something that's really being promoted. How that works, I'm not sure at the moment, because that would obviously need to be to include identifiables and things, but it's certainly something that we want to do. I think at the moment we're just trying to feel out, where do clinicians and teams think that this could sit within the service, and how could it best provide value to patients and also take pressure off treating teams. So that's we're still in a bit of kind of the discovery phase for that. But
thanks very much, that's great.
Any other questions?
I can see Siobhan's joined. So Siobhan, do you want to just say a few words about this? Sorry, because Siobhan's actually led a lot of the content and the design.
Yeah, thanks, George. I've actually been sitting quietly in the corner thinking, thank God you're trying to do the teams and not me, because yeah, it would have self-destructed and not just gone silent if it was me. But yeah, so it's been great. I sort of came into post just after Neil had left the Southwest, unfortunately. So George was a little bit stuck, I guess, would that be fair enough to say, at the time, as Neil had abandoned us for Scotland and sought me out for advice. So a lot of the sort of basic information I've put out and wrote, when I came into post, never ever having heard of My Sunrise, because we didn't have it at that point up in Bath. So I literally came in as a total newbie, but over the course of time have been totally won over. I think the app, we manage. I'm really glad that we stuck hard, and although Neil had abandoned us, as I've told him that as well, he really kindly put together the video, which it's so personable for patients. It's a pity you couldn't hear the volume. It sells it for patients and for healthcare professionals. It splits each video. I think it's no more than 3 minutes now, but it's got the clear animations, and it makes it unique to other apps that there are. I now, being based up in Bath, am really keen to work with SWAG Cancer Alliance. So it was the Southwest GMSA who gave George the funding right back at the beginning, but it was only in Peninsula, hence when you look through all the different hospitals. And what George didn't tell you is if you'd clicked on any of the hospitals which were in the sort of north of our GMSA, all we have access to is the Lynch companion, which, as I said, I think that's amazing. But what is really good is the whole cancer companion experience that George, and I know that's not the point of today, this is sort of selling the app, but the two things go together. And I'm not the expert there, because in our hospitals, in SWAG Cancer Alliance, we don't have the whole thing. But I think it's absolutely brilliant that the Black Country, you're looking at building it, and I would encourage all of you to look at the broader thing, what they're now doing in Cornwall. They're doing chemotherapy consenting appointments through the app, saving money. The limits are limitless. So I just want to brag about that bit, because I had nothing. But hopefully, I was key in getting Neil right in the background. Believe it and promote it, but honestly, we've done everything.
Thanks, Siobhan. I just wanted to just quickly share this with you, which is something that Neil put together, which is a Lynch Syndrome passport that we're developing at the moment. So it looks like a simple table at the moment, but what we're hoping to do is develop this into a digital format where patients can, depending on their diagnosis, they can tick when they've had their bowel screening that they're on aspirin, that they've had H. pylori testing, they've had their genetic testing, they've had a prostate review, then they've had an annual health check. And that is the direction of travel that we're really hoping to go, where patients can actually be empowered to understand what they need each year, and when they haven't had it, they understand how they can get that done for them. And that's where we really hope that that's going to improve adherence to and compliance to this guidelines, which seems to be still a bit undecided and changing, and hopefully that will really have an impact on improving outcomes for these patients. So that's something that Neil's developed with us, and is kind of where we see the phase two work going. So I've just managed to get teams to work. Great. Okay, so I don't notice any more questions, or
we've just got a question, I think, from Charlotte.
Yeah.
Hi, George. Thank you very much for that. And sorry that Teams is such a pain, but I think we all suffer with Teams. But I'm really interested to find out as much as I can about My Sunrise. I have a sneaking suspicion that probably about 7 years ago, you and Neil might have been starting some healthcare app IT type stuff, and I knew someone who had maybe met with you to discuss ways forward. And I was interested at that point and actually thought about contacting you myself to say, oh, I've got ideas. But this is absolutely brilliant. I can definitely see how it can be used in all sorts of other specialties, be that within cancer care, but also could be extended to others. I'm interested in what you've said about Neil as well and the passport idea. Within the CAS GMSA, we've just developed both nursing and midwifery passports so that we have people who develop those. But we've actually been talking about developing patient passports for their care and digitizing those as well. So what I don't want is for us to start moving forwards any further with that if Neil's already working on that. So it'd be great to find out more about what he's doing, because again, duplication is appalling. It confuses patients, it confuses all of us. So it would be great to find out more about his work with that. But yeah, really interested to find out more. And certainly I think within CAS GMSA, it would be great for us to be able to support anything further going forwards. Sorry, I'm the Associate Director of Nursing and Midwifery.
Oh, great, thanks.
Sorry.
Thanks, Charlotte.
Should have introduced myself there.
No, well, thank you so much. I mean, we would be really keen. I mean, I think from the start, we've always felt that this is very important to be a collaborative piece of work with the GMSAs, because it's so key to understand, you know, how these digital tools have the impact and align to service, and that's really been our vision. So bringing in support from and engagement and interest from Central and South Genomics would be fantastic, especially as we're already working in the West Midlands and with the ICS there and the West Midlands Cancer Alliance. So we've been through some of those hoops already in terms of the procurement and compliance and things. So we're really happy.
That would be I'd be interested in talking to you some more, and maybe talking with our managing director and medical director. I'm sure if David is also supportive of it, he can also do a bit of pushing on that. But no, I'm very interested. I mean, partly my background, I worked in theatres, which is not relevant either, but I did work in clinical informatics, where we were designing different installations in different places for informatics. So I worked at Wolverhampton, so that was Black Country as well, with I don't know if you've met Nick Bruce, but with him and others. So be really interested in knowing more.
Okay, great, thanks so much. Well, I'd be really pleased to follow up with yourself, Charlotte, and David and Caroline, Felicity. So I'll drop you an email, and then please get back in touch with any further questions, or I've left a couple of links in the chat just for you to have a look at. Do you download? You can download the app for free today and have a look at the Lynch pathway. The videos are all on there, so you can see Neil doing his voice for radio, which is what he says in the video. It's just quite funny. I'll be really pleased to follow up with you. So thanks for your time.
Thank you so much, George and Siobhan. It's really, really good, and some amazing work going on there. So we'll give everybody a 10-minute comfort break. So if you want to be back just before 10 to, and we'll kick off then with David talking about the Lynch vaccine. Fabulous. So if everybody's back, I'll pass you over to David to talk about the Lynch vaccine.
Thanks very much, Kat. Hopefully you can see my slides.
Yeah.
All good. Great. So it's nice to be able to talk about this. Wearing my other hat, I have a research group here in Oxford, and together with a number of others, we have had an interest in mismatch repair deficient cancers and Lynch syndrome associated cancers for some time. And latterly in Oxford, Sarah Blagden here has done a lot of work setting our stall out as a Centre for Precision Prevention of Cancer. So we're the first Cancer Research UK clinical trials unit focused on precision prevention. And this is a project which I guess combines both of those two aspects. And this is some work we've been doing towards a vaccination strategy for Lynch syndrome. And I'll show you what this means as a concept and where we are both in Oxford and more broadly over the next 15 minutes or so. I hope it's of some interest. Happy to take questions, of course, at the end. So, yeah, as I say, I lead a project group here, which we're calling Lynch Vax, companion project to Lung Vax, and both of which are seeking to prevent cancer by vaccination. So just to remind ourselves of the problem, and apologies to those of you for whom this is unutterably basic, but it's useful just to conceptualize the challenge here. So for instance, in the human colon, there's a huge amount of cell division as we kind of know, but maybe don't have a handle on the numbers. So copying DNA is a massive, massive challenge. In our colon every day, 10 billion cells die and are replaced, and all of them, they need to replicate all their DNA before they divide to replace the cells that have died. So in all of those cells, there's 3 billion DNA bases that have to be copied accurately. So if you think 10 billion cells with 3 billion DNA bases, it's a huge amount of copying of DNA that is going on all the time, completely unbeknownst to us, of course. And the copying of DNA is exceptionally accurate. And if it isn't exceptionally accurate, in fact, if it isn't perfect, there's a mutation. So a base could be misincorporated, or there could be a slippage event, and I'll show you in a minute. And if uncorrected, that leads to an error in the DNA sequence, which we refer to, of course, as a mutation. A sufficient number of mutations in important genes for cell division, for apoptosis, so resisting cell death, means that a cancer can result. So cells can become immortal, can grow and spread, and that's what cancer is, of course. So why do we not get mutations in our DNA as it's being copied at such a scale at far higher frequency than we do? And that's because, and I'll just bring my pointer up, that's because the copying of our DNA under normal circumstances is incredibly accurate through a number of cellular processes. So the mechanisms of DNA replication is there's two principal replicative polymerases, one of which, Pol Epsilon, replicates the leading strand of DNA, and we've done quite a lot of work in our lab over the last 10 years. And Pol D1, Pol Delta, replicates the lagging strand of DNA. And these polymerases are exceptionally accurate. So the actual incorporation of DNA opposite the template strand is very, very accurate. That has an error rate of 1 per million. And then the polymerases have something called an exonuclease or proofreading domain, which double checks that the correct nucleotide, the correct base, has been inserted across from the template strand. And that is confers another level of accuracy, taking that error rate down to 1 per 100 million bases replicated. So already the polymerases, as they copy the DNA at incredible speed in all of our cells as their cells are dividing and the DNA is being copied before that, the polymerases are able to copy the DNA with an accuracy of an error rate of 1 per 100 million. And if there is an error that goes uncorrected by the polymerases, by their exonuclease proofreading, it can be recognized by the mismatch repair system. And this will be familiar to most of us on the call as being the causal defect in Lynch syndrome, of course. But that mismatch repair system is still some debate in the literature about the cue, the signals that it uses to recognise the newly synthesized base and the newly synthesized DNA strand, I should say, and know which of the errors in the DNA is in the new strand rather than the old strand. But suffice it to say, it does so, and it does so with exceptional accuracy. So mismatch repair system scoots up and down the newly synthesized DNA. It recognizes errors that have gone uncorrected by the replicative polymerases, and it's able to recognize them and recruit additional machinery to correct those, and so the DNA can be resynthesized correctly and accurately, so you're not getting mutations in the newly synthesized DNA at a rate far higher than we do. So that accuracy of the mismatch repair system takes the error rate during DNA replication down to 1 per 3 billion bases. So that's basically 1 error per genome per cell division, which is why we don't get cancer at far higher frequency than we do. Now, of course, in Lynch syndrome, individuals are born with 1 faulty copy of a mismatch repair gene, MLH1, PMS2, MSH2, MSH6 being the 4 main genes. So they're born with 1 faulty copy. During adult life, there's a secondary event, which means they lose the backup copy. They lose the second wild type allele of the gene. And consequently, they lose the ability, their mismatch repair system loses the ability to recognize and correct mispairs and insertion deletion mutations. And as a consequence of that, that error rate shifts upwards from 1 in 3 billion to 1 per 100 million bases. So a very substantial increase in the mutation rate in those cells where, as a consequence of Lynch syndrome, they have lost the mismatch repair machinery function. And as a consequence of that, when you've got an error rate that's so much higher, and mutations occurring at such higher frequency, you can get that complement of mutations that you need in essential genes, cancer genes as we call them, which regulate cell division, cell growth, cell death. And if you have a sufficient number of those, which most studies now indicate is somewhere between 6 and 10, depending on the tissue type, you can get a cancer. So uncontrolled replication, failure to die when it should do, etc. The hallmarks of cancer, as those of you familiar with the concept will recognise. And that's why people with Lynch syndrome get cancer with prevalence of up to 80%, as we all know. And that's why we're all working so hard to identify these individuals and prevent these cancers. In terms of the mechanisms of these mutations, there's one type of mutation that deserves particular focus in the context of vaccination, and that's a type of mutation called a frameshift mutation, which I'm just trying to illustrate here. So here we see a sequence of DNA with the nucleotides here, and so the nucleotides are replicated going back to the central dogma to remind ourselves. So every 3 nucleotides are recognized. They can code, as we say, for an amino acid, which are joined together in chains and make proteins. So these sequence of the sequence of DNA codes the particular amino acids, codes the protein. And here we see a sequence of DNA encoding a particular protein chain here with the amino acids as these spheres here. And this bit of DNA here has a particular repetitive sequence here with this run of thymidines, which is referred to as a DNA microsatellite. So a microsatellite is a run of DNA in which a single base or a sequence of bases, a small sequence of bases is repeated. And these arise during evolution. They're unstable during evolution. So we've got many of these in our DNA, both in bits of the DNA that code for protein, the coding genome, and in the non-coding genome. And what happens when mismatch repair function is lost is that the copying of these repetitive bits of DNA is disrupted. And so the polymerases are prone to making errors and slipping when they're replicating these repetitive bits of DNA because they're unable to recognize the length of it. And so you can have bases deleted in the new DNA strand or less commonly inserted. And what that leads to is a slippage event and a new sequence of DNA that's converted into protein. So rather than this protein sequence here terminating at this particular amino acid with the slippage event and this frameshift mutation, as we call it, you get the DNA a new sequence of DNA. And so instead of the protein sequence stopping here, it continues, and you have these new amino acids and a new bit of protein here. Okay, so that's something called a frame shift mutation, and this new bit of protein here can be antigenic, so it can be recognized by the immune system. That's referred to as a new antigen, and that's what we're showing just here. So normally the reason that our immune cells don't attack our proteins is because they're tolerized to them. So proteins are chopped up into peptides. Little bits of proteins are always shown to the immune system. And during the development of our immune system, they're shown normal proteins in the thymus, and they're told through signals that they're given that these are normal proteins and they shouldn't go after them. They shouldn't attack them. Okay, so they are recognized, as we refer to them, as self by the immune system, and therefore they're not attacked by immune cells, particularly these cytotoxic T cells, which are the key players here in anti-cancer immunity. But in the context of mismatch repair deficiency and a frame shift mutation, this new protein sequence, when that's presented to the immune system by HLA molecules on the surface of cells throughout the body, that can be recognized as non-self. So the immune system has not seen this abnormal protein sequence before in the thymus, and then it's recognized as foreign. And this is the same principle by which the immune system recognizes and destroys viral DNA or bacterial DNA. So it's involved with that, but it's also important for cancer immunosurveillance. And so the cytotoxic T cell here is able to recognize the abnormal protein bound on class 1 HLA molecules on the surface of cells, and it's able to lyse those cells both directly and by recruiting other molecules, the details of which we don't need to go into for purposes of this talk, but the net result is killing of the cell bearing this abnormal frame-shifted protein. But cancers are sneaky, and they find ways of escaping from the immune system, escaping immunosurveillance, as we call it. And one of the mechanisms they do this is, there are multiple mechanisms, but one of the key mechanisms they use is to upregulate what we call immunosuppressive immune checkpoints. And these will be familiar to you through the drugs that we use, which I'll show you in just a second. But two key examples that we target in the clinic are the molecule PD-1, which is expressed on immune cells, and the molecule PD-L1, the ligand, which is expressed on incipient cancer cells and cancer cells. And collectively, these upregulation of these molecules induce something which we refer to as T cell exhaustion. So the T cells, unlike normal functional T cells, are unable to kill cancer cells bearing these abnormal proteins, even though they're being shown to the immune system, because they have upregulation of these molecules. And of course, these, as I've said, are the targets of immune checkpoint blockade. So we have anti-PD-1 drugs, nivolumab, anti-PD-L1 drugs, for instance, avelumab, which have demonstrated remarkable activity against mismatch repair deficient and Lynch syndrome associated cancers in the clinic. So many of you on the call today will have patients who have metastatic mismatch repair deficient cancers who've used these drugs, and in comparison with conventional cytotoxic chemotherapy, where responses are present but relatively short-lived, these drugs don't just have very deep responses with unprecedented response rate in metastatic mismatch repair deficient cancers, but they also induce really prolonged responses. So we have patients now who had more than 2 years of immunotherapy for mismatch repair deficient colon cancer, for instance, who are now clinically free from disease. So they really are so efficacious because they're re-energizing the immune system against the many frame shift mutations that these mismatch repair deficient cancers carry. And what does vaccination do? Well, it really, in very simple terms, accentuates the immune system, the immune response. So the mechanisms by which it does so are, I suppose, are still being elucidated. Really, we don't know everything there is to know about it. But the mainstays of vaccination efficacy is either humoral, so an antibody-mediated, or a cell-mediated, which is what we're interested in for anti-cancer vaccination, immune response against these frame shift proteins. These are neoepitopes, as we call them, so mutations that are capable of causing abnormal proteins, which can be recognized by the immune system. So we want to pre-warm the immune system with vaccination about these proteins and therefore turbocharge its immune response if and when they occur in an incipient cancer or cancer in people with Lynch syndrome. So here you're seeing a very cartoon description of the turbocharged immune system that's enabled to kill these cells before they become cancer and upregulate these immunosuppressive mechanisms such as upregulation of PD-1, PD-L1. So that's the overarching rationale behind a vaccine for Lynch syndrome targeting frameshift mutations. And it's important to note that Lynch syndrome offers many such targets. So these DNA microsatellites, which are subject to the frameshift mutations, are extremely numerous through our genome. So this is the basis of DNA fingerprinting. So forensics using DNA relies on the variability in these microsatellites between individuals, and there are many of them to look at. So in just the protein coding genome, which is 1% of our whole genome, there's more than 400,000 DNA microsatellites and more than 400,000 potential vaccine targets if they make abnormal proteins which can be shown to the immune system. And many of these alterations, many of these frameshifts will make abnormal proteins that the immune system can recognize. And I'll show you some more work that we've done in that space in just a second, but this is a paper from a few years ago looking at endometrial cancer here, so uterine corpus endometrial cancer as the abbreviation goes here, stomach cancer here in the middle, and colorectal cancer here. And what this is showing us is the percentage of each cancer type, or cancers of each type, I should say, that have a frameshift mutation or a mutation in these genes. So here on the x-axis, we see these various different genes, all of which carry DNA microsatellites within them, all of which can be subject to these frameshift mutations, changing the sequence of the gene and the sequence of the protein it makes and causing an antigenic protein, an antigenic variant that could be potentially be recognized by the immune system. And you see here, these are occurring at very high frequency in these cancer types. So more than 50% of tumors having mutations in these genes in this particular study. So the targets do appear to be there in the cancers with mismatch repair deficiency, some of which will be due to Lynch syndrome in this cohort. And we're not the only people to recognise the potential for this vaccination, unsurprisingly. And one of the vaccines that's furthest in clinical development, which some of you probably heard of, is a vaccine made by an Italian biotech called Nuscom. And they have the NUS 209 vaccine. So what they've done is they've used these data here to identify the frameshift mutations in these cancer types. And what they did was to identify, using this data set, those frameshift mutations which are present in more than 5% of cancers of any type with mismatch repair deficiency. And they identified 209 such targets. And then they've built a vaccine against those. So thus far, it's been tested in patients with advanced bowel cancer and been found to be safe. There is some evidence in the early studies of an immune response. Whether that is specific to the targets that are in the vaccine or non-specific is not really clear at the moment, but it's currently under analysis in people with Lynch syndrome in the US. And for those of you at the Lynch Syndrome UK talk, which I gave a little earlier this year on this subject, there was one particularly vocal audience member whose son actually had gone to the US for this vaccination study, who had quite a lot to say on the subject, I think it's fair to say. So, as I say, early results from the studies of the Nuscom vaccine suggest that it is activating the immune system. Whether that's specific or not, or non-specific, is not clear at this moment in time, and it's too soon to make any evaluation of its effectiveness. So the next step will be to see whether it reduces polyp burden in people with Lynch syndrome when given to them. But that's the Nuscom vaccine. We have our own vaccine project, the LynchVac study, as a project, as I call it. It's the University of Oxford project, and we've used a different search strategy to Nuscom. So rather than using data from the Cancer Genome Atlas, which is a big US study, we've used data from the UK Genomics England program, which has quite a few advantages over the TCGA study, not least that it's genome sequencing versus exome sequencing, for those of you in the know about those kind of things. Also much deeper sequencing, so we get better delineation of the frameshift landscape. And we've also taken the approach that, or the mindset that if we want to prevent precancers, which is what we want, we need to understand precancers. So we've also done a good bit of analysis of precancers in people with Lynch syndrome. And this is where we've got to so far. So using 2,000 colorectal cancers with whole genome sequencing from the Genomics England project, and nearly 700 endometrial cancers, we've identified those cancers that have mismatch repair deficiency. Now, most of these are not Lynch syndrome, but the molecular mechanism is the same. And we know that there are about 20 Lynch syndrome cancers in this cohort and about 16 Lynch syndrome cancers in the endometrial tumours. And then we've pulled out from those good number of mismatch repair deficient cancers, which I think it's important to say is substantially more than newscomer views from TCGA. We've pulled out all of the recurrent frameshift mutations. And what I'm showing you here is those coloured in orange are those frameshift mutations which occur in more than a quarter of mismatch repair deficient bowel cancers, colorectal cancers here, and more than a quarter of mismatch repair deficient endometrial cancers here. And so you see here these highly recurrent mutations, this particular one here present in 87% of mismatch repair deficient colorectal cancers, and the frequency of these frameshifts slightly lower in endometrial cancers, but still, you've got a very substantial number that are present in more than a quarter of tumours. And if you just intersect those frameshift mutations, you find here that there's 29 that are present in more than 25% of each tumour. So these would be potentially good vaccine targets that we could take forward. So we've taken those forward, and by analysis of pre-cancers in people with Lynch syndrome who have surveillance colonoscopies here in Oxford, we've collected samples under informed consent for research. Here you see where these precancerous polyps have come from in people with Lynch syndrome. We've done genome sequencing and RNA sequencing and also some other analysis of protein, which I'll show you in just a second. And what we're looking at here is a little bit technical, but I'll just walk you through it. Here we're looking at the number of mutations, so errors in their DNA of these precancers. And we see here there's a subset that are highly mutated, have a high number of mutations in their DNA. And also this red line here is to show you the proportion of unstable microsatellites. So this is the readout of microsatellite instability. So you see that the highly mutated precancers also have microsatellite instability consistent with loss of DNA mismatch repair. That's backed up by analysis of mutational signatures, which we're seeing here. Interestingly, it's only the adenomatous polyps here which have the microsatellite instability and the hypermutation, increased mutation burden. The serrated lesions in these patients do not, or these individuals, I should say, they're not patients, do not. And what we're seeing here is really the key finding is that of these 29 frameshift mutations we've defined in the colorectal and endometrial cancers from Genomics England, we already find these tiny precancers, many of these less than 5 millimeters across, that these frameshift mutations are already there. So here we see this polyp here has 10 of the 29 frameshifts. This polyp here, very small lesion, already has 17 of the 29 targets. So, potentially this supports, or not potentially, this supports the notion that these might be vaccine targets. Of course, there's more work to do here, though. So in terms of next steps for the project, we've just been successful in securing further funding from Cancer Research UK to extend this. So we'll be doing more colonic polyps in people with Lynch syndrome, and also extend it to endometrial cancers and other mismatch repair deficient tumour types. We will be confirming that these targets that we found in the cancers and the precancers are immunogenic, so synthesizing these abnormal proteins and seeing if they stimulate immune response in people with Lynch syndrome and healthy volunteers, and then prioritizing those targets to put into a vaccine. And we're actively pursuing discussions with industry to get a vaccine partner for this, because we know that although we can work up a vaccine in academia, timescales at which we can do that are not orders of magnitude slower, but substantially slower than industry, where they're doing this thing at scale, of course. We have a very, very strong and engaged patient and public involvement group, actually, who are incredibly helpful. And many of you on the call will know several of them, including Tom Bartlett, who's spoken at previous events, actually. So what we're going to do as part of this work is really to actually get user input, or potential candidate user input. So we know that with the pandemic, of course, that we had an effective vaccine against COVID-19, but not all people took it, not all people wanted it. There's a lot of misinformation, a lot of concerns there, which we really want to capture through our PPI involvement, and we'll seek to do so during the project, of course. So I hope I've just shown you the molecular background to why vaccination for Lynch syndrome is an attractive concept. Shown you some of the scientific progress that means that we're actually, I think now it's fair to say, getting close to being able to deploy vaccines for Lynch syndrome. We don't know at the moment which the best targets or best approach is. Should it be an adenoviral backbone or an mRNA backbone? We don't know yet. But the work that we're doing in Oxford and elsewhere will help to define this. Proven a little way off, but obviously we'll keep all updated. And will any open vaccine trials that we're able to bring to the UK, there's obviously a big UK initiative for cancer vaccine trials at the moment, we'll signpost it and make sure that you're aware of it for your patients and Lynch syndrome carriers, of course. So big group, big thanks to Francoise, who is the project manager for the group, and also many others who've done the work. Big thanks, of course, to the PPI group, who I've just flagged here and mentioned before. And that is me done, and very happy to take any questions, of course. So I will stop sharing my screen if that's okay. And open the floor if there are any questions. None. Great.
Stunned us all in the amazing work.
No, it's really good, really good.
Well, it's I'm just the front of house guy, so it's the others that do all the real work.
I think from a patient perspective, it's amazing. I mean, when you did your talk at the Lynch UK event, there's so much buzz around it, and it will really make life changing.
Yeah, we hope so, and this is part of an overarching strategy. So the LungVax trial, and no one on the people on the call might not know, but that's to prevent lung cancer, and so similar approach, identifying targets in the analysis, and that that's very exciting as well. So there's a huge amount of excitement in this space. So yeah, great.
We've got a question from Claire. She's asked, she says, it's so interesting and amazing. When will we expect results?
Yeah, so the NewsCom, there should be some readout from the NewsCom vaccine in the next couple of years, actually. One of the challenges is that we don't really want to wait for people to get cancer. So waiting for cancer is, you have to wait potentially a long time for people to get cancer, and also you would need very large numbers. So we're very interested in the possibility of using surrogate or defining surrogate endpoints, and one possibility is using aberrant crypt foci, which we're quite interested in. So that's these abnormal clonic crypts which they have loss of mismatch of pair. If we could validate those as a surrogate for efficacy of the vaccine, potentially we could speed things up very substantially. So that's something that Simon Leedham, who's a gastroenterologist here in Oxford, and I are very interested in, actually.
Brilliant. And Charlotte Hitchcock says, great to hear more about exactly what's happening in this area.
It's a pleasure, Charlotte, and look forward to updating again, I hope.
Yeah. Brilliant.
Great. Thanks very much.
Fabulous. Thank you very much, David. I think we are due to talk a little bit about sustainability, which I think a lot of people are itching to know about. So I'll pass you over to the lovely Caroline to kick us off with that.
Thanks so much, Flick, and thank you, David. Brilliant work and revolutionary, really, for patients and care. So brilliant. So I'm going to talk a little bit about sustainability. So the NHS sort of genomic strategy, the priorities were about embedding genomics across the NHS, and that's really through sort of a world-leading innovative service model from primary community care and then through to sort of specialist and territory care. Again, we've talked about earlier that delivering that equitable genomic testing, because that's going to improve outcomes for care, sort of for cancer, rare inherited diseases, and obviously the most common diseases as well. It's also about sort of enabling that precision medicine and reducing the risk of sort of adverse drug reactions as well. It's enabling genomics to be forefront in both the data and digital revolution, and ensuring that genomic data can be interpreted and informed by other diagnostics of clinical data. And it's about evolving the service through cutting edge science, research and innovation, obviously ensuring that patients can benefit from sort of rapid implementation of advances. So sustainability. So we had a report that came out from the Cancer Alliances at the end of April. And the main thing that they really said was that responsibility for funding for Lynch should transfer from the Cancer Alliances to the ICBs. And that coincided with the end of the transformation project. So they're saying that key services still need to continue to be commissioned. So the Cancer Alliances were asking the ICBs to ensure that they'd got funding for all trusts with pathology services to enable us to provide sort of the immunohistochemical testing for Lynch, and also to support sort of those local pathways that are focused on the diagnosis for all patients that had got endometrial and colorectal cancers. And making sure that sustainable Lynch testing was going to be audited, and that where funding was not agreed, we would seek to work with the local ICBs to understand the barriers to funding, and obviously support with the next steps. So where did we go from this? So we ran a training event back in May for all the ICBs within the West Midlands. There was really good attendance for this event, and that they were quite keen, really. They were really positive. We have made contact with Buckinghamshire, Oxfordshire, and the Berkshire West ICB, Surrey, Sussex, and East of England, alongside sort of Bath and Somerset, who cover a lot of our different trusts. We have had a meeting with the East of England, who cover Milton Keynes, but we're still pending meetings for the others at the moment. We've also had yesterday an email that's come out from the Cancer Alliance to say that if there are issues with funding going forward, we have now got a way of escalating those issues, and we can do those on our quarterly reports. So if people are struggling and you're not getting anywhere, just let us know, because we have got a way of reporting this and highlighting it to the Cancer Alliances so that we can support sustaining services moving forwards. So the GMSA, which is who we as a project team work for, we're really keen to support sustainability of the work that you've been doing. It's amazing. It's been really, really good for patient care. So we can assist with things like business case writing. So if you're struggling, you need extra support, be it clinical, be things like cancer navigators, we can help you do a business case for putting that forward. Same with sort of bid writing, maintaining contacts, and obviously pushing sustainability, so we can put you in touch with your local ICBs. And we're the hosting sort of central team for sort of West Midlands events for the ICBs and also Thames Valley. I'm just going to pass you over to Felicity just to go through the last few slides.
Thanks, Kat. So really where to start. So we were very lucky. The national team have put together a document which basically gives you information in order to kind of help with your business cases, really. So it's really good. It just contains like patients sort of patient experiences and really how to or where to sort of direct funding, really. Then that we're very welcome. We've passed that obviously to the ICBs, but we can also obviously send yourselves a copy, which we will do along with the slides from this morning. Next slide, please. And then really we were asked a question actually by one of the ICB members, and that sort of started off sort of another little rabbit hole for us in terms of really how we go around assessing the change that we've made with this project. We know that we're making a difference, but actually how can we assess this in order to support our bids, our business cases, and obviously sustainability of service going forward? One of the things that we sort of looked at is, and a lot of teams do, they re-audit. So the initial audit that we gave to teams, people have looked and used that, but that doesn't quite cover really your service from a mainstreaming perspective. So again, you know, you may want to come up with your own audit, but actually there is an evaluation impact framework that's been developed by NHS, and the link of that is obviously on this slide. And obviously we want to basically showcase the good work that you're doing. Other ways for us to sort of look at actually how busy, what's our throughput. So again, you can use obviously whatever you use to put your appointments on, so you can use those sort of those as documents, and also use services like Infoflex and Somerset, because hopefully you should be putting in when you're actually meeting those patients as well. And all that hopefully will just act as extra evidence to help support your business cases. Next slide, please. And then obviously we were also asked and tasked with, from a national perspective, actually where we see things going. And obviously I won't read the whole table out, but basically there's 4 main areas that we were particularly looking at. We want to continue obviously the education within our MDTs, and that encompasses all persons, like we've mentioned before. We want to reduce this idea of that it's always somebody else's responsibility. We want to empower MDT coordinators or nurses or anybody within the MDT to ask that question: has this patient had their MMR status done? Because I'm a colorectal nurse by trade, you know, invariability, oh, can't even say the word, you know, sometimes patients do fall through that net. So actually, if people are all asking that question, hopefully that helps to reduce that idea of it always being somebody else's responsibility. We want to continue our collaborative work with ICBs. As Kat's already touched on, we had a really successful catch-up meeting with our local ICBs within the West Midlands, and that was really because they didn't have a clue who we were. So we wanted to introduce them to the project team. We wanted to introduce them to the project and actually use and showcase the amazing work that's already been done. Obviously myself and Kat are very much at this idea of world domination. So we also are looking at obviously getting within sort of GP and community services, because again, they are front house quite often. And again, we want to make sure that patients who are diagnosed with Lynch have a GP service that they feel that they can access and feel that they will be referred or supported in the best possible way. And also the things like obviously supporting them with the H. pylori testing and obviously aspirin as well. So again, that's also another key area for us. We want to continue working with cancer and nursing networks to help educate. Obviously we're part of the GMSA. We also have a nursing network that obviously Charlotte's you've met already on this call, but we've also got Phil, we've also got a midwife. We are part of their work towards getting genomics out there for actually it to not be to be a normal part of our nursing or medical careers, that actually goes from niche to normality. That seems to be one of the key terms that we say. So we are very much part of that work as well. We also want to continue the work with charities. We've mentioned some this morning. Obviously, again, we are working with charities to help reduce inequalities within access of healthcare services. We also again want to be able to work with charities to produce information leaflets or help promote these discussions with GPs and persons to ask this question around genomics, and particularly Lynch. And again, as we said, working with groups to help develop resources for underserved communities, again, to give them the power back, give them back autonomy. Next slide, please. So again, just to reiterate with what Kat said, if there's any questions that you've got in terms of this sustainability after this call, or you want help and support, then obviously do get in touch with us, and we can help support that. So thank you ever so much. I know we've, well, we're right on the nose. So I know some of you may or only have a very short amount of time. We will send the recordings out, but if you've got any questions that you want to go through on anything that we've spoken about or anything in general, then say now, forever hold your peace. Fall into wedding mode there, sorry. We stunned you all into silence.
Thanks. So just to clarify, thanks again, Flick, Kat. Fantastic as usual. Just to clarify, we're going to have recording of this on the website, and we'll circulate that, and some feedback as well, won't we?
Yeah.
Fantastic.
We'll be hosting another in-person event, so you're not getting rid of us just yet. So our next in-person event will hopefully be in October. We're just sorting out venues, and we'll send out the details as soon as we know. But yeah, it'd be great to have you all there. And if there's anything you think that you would like, we'll send out feedback, but if there's anything you feel that you feel's missing, that you would like us to expand on, again, do let us know, because that will help sort of aid our future planning for the next event. Fabulous. Well, all that's left to say is I just again just echo what Kat said at the very beginning. Just a huge thank you to everybody with all the hard work that you've done to support this project. It's not easy, and we're quite up against the wall. We know that you're very busy, so just the biggest of thank yous for putting up with us, but also all the work that you've been doing.
Yeah, ditto, echo that strongly.
And also to genetics, I just want to say to genetics as well. I see Kyren's there. Honestly, they've been absolutely phenomenal. So again, just a huge thank you to genetics for all their support.
Yeah, not just because you turned your camera on there, Kyren.
Yeah.
Great.
So brilliant. Well, if there's nothing left to say, I'll let you get back to your life.
Thanks so much,
guys.
everybody.
Thank you.
Bye.
Bye-bye.
Bye.
Bye-bye.